Drugs to treat inflammation, steroidal and nonsteroidal anti-inflammatories. At the end of this, students should be able to differentiate between the actions of steroidal and nonsteroidal anti-inflammatory medications on the inflammatory process, contrast the functions of COX-1 and COX-2 inhibitors, compare the adverse and toxic effects of corticosteroids, aspirin, non-selective COX inhibitor NSAIDs, and the COX-2 selective drugs, and describe anti-inflammatories commonly used in the athletic training setting. Inflammation is a complex response to cell injury that primarily occurs in vascularized connective tissue, with inflammation mediators functioning to eliminate the cause of the cell injury and clear away debris in preparation for tissue repair. The response is activated by noxious agents, infections, or physiological injuries that release damage and pathogen-associated molecules, which are then recognized by the immune system cells. Pharmacological interventions for inflammation involve the large category of anti-inflammatory drugs, which are directed at controlling the inflammatory process and minimizing inflammatory pain. The two major classes of anti-inflammatory medications are the corticosteroids, specifically the glucocorticoids, and the nonsteroidal anti-inflammatory drugs, or NSAIDs. When tissue damage occurs, regardless of the mechanism, a transient local vasodilation and increased capillary permeability occur. Vascular changes account for the familiar clinical signs of inflammation, including redness, heat, pain, and swelling. Vasodilation and increased blood vessel wall permeability are the most consistent vascular responses. Vasodilation accumulates as an increase in blood vessel flow or hyperemia, producing redness and heat. An increase in the permeability of the vascular endothelium allows exudate of plasma, producing swelling and pain. Both vascular changes are brought about by local chemical mediators, or cytokinins. These substances are either released by damaged cells or synthesized within injured tissues. These include histamine, bradykinins, prostaglandins, and a variety of other complex agents. When tissue damage occurs, regardless of the mechanism, transient local vasodilation and increased capillary permeability occur. The three major phases of acute inflammation are as follows: vascular phase, a cellular phase, and a tissue healing or granular phase. In the vascular phase, this follows tissue damage or the introduction of a pathogen to tissues. Vasoactivation of mediators, the cytokinins, cause the arterioles to dilate and endothelial cells to shrink, making capillaries and venules more permeable. Increased intracellular permeability allows extravasation of the plasma, leading to swelling and pain. During the cellular phase, within a few hours of the vascular change, chemotatic mediators, large target leukocytes or white blood cells, which adhere to the endothelium or margination, squeeze through the openings, also known as diapedesis, in the capillaries and migrate out into the tissues. Additionally, chemokines attract macrophages to the site of inflammation. Tissue healing, or the granular phase. Within 6 hours after the onset of inflammatory response, macrophages arrive at the damaged tissue. Activated macrophages secrete three major pro-inflammatory cytokinins. These cytokinins induce coagulation, increase vascular permeability, and promote the acute phase response. Chronic inflammation results from continuous or repeated exposure to the offending element or process. This physiological process can result from continued tissue damage, persistence of pathogens, autoimmune disease, or cancers. The hallmark of chronic inflammation is the accumulation and activation of macrophages and lymphocytes, as well as fibroblasts that replace the original damaged or necrotic tissue. The replacement of the damaged tissue leads to fibrosis and the potential formulation of granulomas. This is figure 9.1, illustrating the major events in the acute inflammatory process. Controlling inflammation. Many drugs are available to decrease joint pain, swelling, and inflammation and possibly prevent or minimize the progression of the inflammatory response. The two major categories of anti-inflammatory drugs are as follows: corticosteroids, such as prednisone or hydrocortisone, and nonsteroidal anti-inflammatory drugs, also known as NSAIDs, such as aspirin, ibuprofen, or naproxen. These medications help to relieve pain, swelling, and help minimize the progression of illnesses. NSAIDs inhibit the vascular phase of inflammation, and corticosteroids inhibit primarily the cellular phase of inflammation. Corticosteroids function to profoundly alter the immune response of lymphocytes. This is an important aspect of the anti-inflammatory and immunosuppressive actions of these drugs. Anti-inflammatory medications function to inhibit various parts of the arachidonic acid cascade. Non-selective NSAIDs target cyclooxygenase, also known as COX, the rate-limiting enzyme in the production of prostaglandins. In contrast, corticosteroids prevent the liberation of the arachidonic acid from the plasma membrane phospholipids, thus reducing the synthesis of the echinocyaninoids. Corticosteroids, also called glucocorticosteroids or steroids, are endogenous hormones such as the glucocorticoid cortisol that are secreted naturally by the zona fasciculata of the cortex of the adrenal glands. Cortisol is released in response to stress and has numerous effects on the body that are essential for life. Corticosteroid medications are a synthetic version of cortisol, such as a cortisone, prednisone, or hydrocortisone, that are very effective at reducing inflammation and suppressing the immune system. Corticosteroids have historically been used for pain relief in the inflammatory conditions. These drugs are frequently prescribed classes of drugs. Because corticosteroids exert effects on almost every organ system, extended administration and withdrawal that is made too rapidly may be complicated by serious side effects. The decision to institute therapy with systemic corticosteroids always requires careful consideration of the relative risks and benefits in each patient. Table 9.1 lists examples of corticosteroid anti-inflammatories. Corticosteroids, the therapeutic effect. Corticosteroids inhibit the inflammatory response to tissue injury. Endogenous corticosteroids also suppress manifestations of allergic diseases due to the release of histamine from mast cells and basophils. These anti-inflammatories require high levels of circulating corticosteroids and cannot be produced by administering exogenous corticosteroids without producing the other manifestations of the corticosteroid excess. Large doses of exogenous corticosteroids inhibit adrenocorticotropic hormones, ACTH, released from the pituitary gland. ACTH stimulates the release of cortisol from the adrenal cortex. ACTH secretion to the point of severe adrenal insufficiency can be a dangerous problem when therapy is stopped abruptly. However, local administration of corticosteroids, for example, by administration into an inflamed joint or near an irritated nerve, produces a high local concentration of the steroid, often without enough systemic absorption to cause serious side effects. The figure on the right is the hypothalamic pituitary adrenal axis. Corticosteroids mechanism of action. The primary mechanism of action for the corticosteroids includes both an anti-inflammatory and an immunosuppressive action. These drugs function to decrease inflammation by suppression of the migration of polymorphonuclear leukocytes and reversal of increased capillary permeability. Multiple other mechanisms involve the suppression of inflammation by corticosteroids and include the inhibition of the production of factors that are critical for generating the inflammatory response, decreased release of vasoactive and chemoattractive factors, diminished secretion of lipoactive and proteolytic enzymes, decreased extravasation of leukocytes to the areas of injury, and decreased fibroblast activity at the site of injury. The routes of administration of corticosteroids. Corticosteroids are used to treat a variety of inflammatory conditions and can be administered intravenously, orally, intraarticularly, topically, intralesionally, or transcutaneously. Corticosteroids marketed as anti-inflammatories are often topical formulations, such as nasal sprays for rhinitis or inhalers for asthma. Prednisone is one of the most commonly used corticosteroids because of its low cost and it's available only in an oral form. These medications should be administered with food to decrease GI upset. Some corticosteroids are formulated in a way that extends their duration of action. For example, depot preparations of methylprednisone provide anti-inflammatory effects for 1 to 4 weeks. The long-acting repository or depot formulations are intended for intramuscular or intra-articular injections. The dosing guidelines. Dosing of corticosteroids depends on the condition being treated and the response of the patient. For patients who are taking corticosteroids long-term, the provider may prescribe extra doses during times of acute stress, such as severe infection or surgery. Corticosteroids mimic the corticosurge that is normally produced in the body, particularly during stressful events, so that healing is not delayed or incomplete. Discontinuation of therapy that has lasted longer than 7 days may require tapering of the drug to prevent adrenal crisis. Standard formulations of prednisone, methylprednisone, and triamcinolone last for around 12 to 36 hours in the body, where dexamethasone and betamethasone last for 32 to 72 hours. Dose requirements are variable. Individualized doses are based on disease and patient response. For example, a Medrol dose pack is a low-dose oral corticosteroid treatment course used in sports medicine to treat lower back injuries and other musculoskeletal conditions. This pack contains 21 tablets of 4 milligrams that are taken over a 6-day period. When corticosteroids are administered at recommended dosages for short durations of time, these potent anti-inflammatories are considered safe. More regular or extended dosing has been associated with severe adverse effects. Use of high-dose corticosteroids, particularly long-term, can cause avascular necrosis, especially in the head of the femur and the humerus. The reasons are unknown, but one hypothesis is that the corticosteroids can increase lipid levels in the blood, thereby reducing blood flow. If untreated, avascular necrosis can worsen with time, and eventually the bone can collapse. Corticosteroids, the indications and precautions. Short-term administration for acute episodes or exacerbations of corticosteroids may be prescribed for patients with acute and subacute bursitis, acute nonspecific tenosynovitis, ankylosing spondylitis, epicondylitis, post-traumatic osteoarthritis, and several types of arthritis. Prolonged use of corticosteroids may result in immunosuppression that increases the incidence of secondary infection, masks acute infection, prolongs or exacerbates viral infections, or limits the response to certain vaccines. The adverse effects. In some cases of adrenal insufficiency, there is a suppression of the HPA axis in patients receiving high doses of corticosteroids for prolonged periods of time. With prolonged suppression, the adrenal glands atrophy and can take months to recover full function after discontinuation of the exogenous corticosteroid. Overuse of steroid joint injections may also result in adrenal suppression after their discontinuation. Withdrawal and discontinuation of the corticosteroid should be conducted slowly and carefully. Adult patients receiving greater than 20 milligrams per day of prednisone may be most susceptible. Thus, it is critical for any patient prescribed corticosteroids to follow precise instructions of the daily schedule without deviation. Corticosteroids have been associated with many side effects, including agitation and irritability, blurred vision, difficulty concentrating, dizziness, facial hair growth in female patients, fast and irregular heartbeat, fluid retention, headache, high blood pressure, increased blood sugar, cholesterol, or triglycerides, increased risk of gastric ulcers or gastritis, loss of potassium, shortness of breath, sleeplessness, and weight gain. While this is not a comprehensive list of all the side effects, athletic trainers should consult with the prescriber with any additional questions or concerns. Corticosteroid use is preferred for pregnant women with musculoskeletal inflammation late in pregnancy because NSAIDs are contraindicated during the third trimester. Additionally, corticosteroids are used during pregnancy to treat autoimmune disorders of the mother that could be more harmful to fetal health than high doses of medication. A historical link was found between corticosteroids and cleft lip births. However, contemporary evidence indicates this incidence is modest. Other corticosteroid risks during pregnancy include preeclampsia, low birth weight, preterm birth, and potential hypoglycemia and ketoacidosis for the patient with gestational diabetes. Corticosteroid use following birth can disturb normal lactation, but this is reversible after stopping to use the medication. Nonsteroidal anti-inflammatory drugs, also known as NSAIDs. These are among the most commonly used groups of drugs. More than 20 different NSAIDs are available commercially, and these agents are used worldwide. All the NSAIDs, including aspirin, have analgesic, antipyretic, and anti-inflammatory effects. The traditional non-selective NSAIDs also have antithrombotic effects. These medications relieve pain by blocking the production of pain signaling molecules. One of the steps in this pathway involves certain types of cyclooxygenase or COX-1 and COX-2 enzymes. By inhibiting the COX enzymes, NSAIDs relieve pain in joints, muscles, and other soft tissues. This is Table 9.3, examples of non-selective COX inhibitors and selective COX-2 inhibitors. The therapeutic effects of NSAIDs. The NSAIDs are antipyretic, analgesics, and anti-inflammatory medications. NSAIDs provide mostly symptomatic relief from pain and inflammation associated with musculoskeletal disorders, such as strains, sprains, and various symptoms associated with rheumatoid arthritis and osteoarthritis. NSAIDs are effective against inflammatory pain of low and moderate intensity, although their maximal effect is generally less than that of opioids. NSAIDs lack the unwanted adverse effects of opioids in the central nervous system, including respiratory depression and the potential for the development of physical dependence. Co-administration of NSAIDs can reduce the opioid dose needed for sufficient pain control and thus reduce the likelihood of adverse opioid effects. Postoperative pain or pain arising from inflammation, such as arthritic pain, is controlled well by NSAIDs, whereas pain arising from the hollow viscera usually is not relieved. An exception to this is menstrual pain. Treatment of menstrual pain with NSAIDs is often useful. NSAIDs are commonly used to treat migraine attacks and can be combined with antiemetics to aid in relief of nausea. NSAIDs and opioids generally lack the efficacy in neuropathic pain, such as diabetic neuralgia, or pain associated with shingles. However, Steroidal, 60 milligrams administered intramuscularly, has been shown to produce analgesia equivalent to morphine for this type of pain. The mechanism of action. The classic COX inhibitors are not selective and inhibit all types of COX enzyme activity, thus impairing the ultimate transformation of arachidonic acid to prostaglandins, prostacyclin, and thromboxanes. The resulting inhibition of prostaglandin and thromboxane synthesis has the effect of reduced inflammation as well as antipyretic, antithrombotic, and analgesic effects. NSAIDs affect pain pathways in at least 3 ways. Prostaglandins reduce the activation threshold at the peripheral terminals of primary afferent nociceptive neurons. By reducing prostaglandin synthesis, NSAIDs decrease inflammatory hyperalgia and allodynia. NSAIDs decrease the recruitment of leukocytes and thereby the production of leukocyte-derived inflammatory mediators. And NSAIDs that cross the blood-brain barrier prevent the generation of prostaglandins that act as pain-producing neuromodulators in the spinal cord dorsal horn. The route of administration for NSAIDs. NSAIDs are used for the treatment of mild to moderate pain, especially for the pain associated with musculoskeletal inflammation, such as arthritis or gout. The primary route of NSAID administration is oral for both prescription and over-the-counter medicines. Toradol is the only NSAID routinely administered via the paraenteral route. Typical NSAIDs have decreased systemic exposure compared to the oral and intravenous formulations. Therefore, they are expected to cause less serious side effects. Although topical and oral NSAIDs may produce similar efficiency, patients receiving topical NSAIDs reported fewer GI side effects compared with those using oral formulations. The cardiovascular and renal safety profile of topical NSAIDs remains to be assessed, and the possibility of skin rashes due to topical application of NSAIDs should be kept in mind. However, the lower systemic exposure that is expected from topical usage may result in a better overall safety profile for those routes of administration. The pharmacokinetics. The major differences between NSAIDs are their therapeutic half-lives and safety profiles. NSAIDs are systematic drugs that are distributed throughout the body and readily penetrate the synovial joints, which makes these drugs ideal for reducing musculoskeletal inflammation. Absorption and distribution. The absorption, it reaches plasma concentration in 2 to 3 hours. After oral administration, the absorption of NSAIDs is generally rapid and peak plasma concentrations are reached within 3 hours. For distribution, NSAIDs bind to plasma proteins. They are usually metabolized in the liver and excreted in the urine. Most NSAIDs are extensively bound, 95 to 99% to plasma proteins, usually albumin, and achieve sufficient concentrations in the central nervous system to have a central analgesic effect. Metabolism. Common NSAIDs have a variable half-life and undergo the first-pass metabolism, which reduces bioavailability. Ibuprofen and diflunac reach a steady state in 1 to 4 hours. Excretion. Most of these drugs are primarily renally excreted. The contraindications. NSAIDs are not recommended in patients with advanced hepatic or renal disease due to the drug's potential altered pharmacokinetic effects, which can increase adverse pharmacodynamic effects, including increased risk of bleeding and increased kidney injury. The precautions and adverse effects. Safety concerns exist for NSAIDs used in patients with or at elevated risk for cardiovascular disease, diabetes, or thrombotic events. NSAIDs should be avoided in patients with renal insufficiency, GI bleeding, platelet dysfunction, reduced cardiac output, difficult to control hypertension, hypovolemia, hyponatremia, aspirin-sensitive asthma, or cirrhosis. NSAIDs may have a drug-drug interaction that induces hypoglycemia among pre-diabetic or diabetic patients prescribed with other drugs. Prescribers must use caution to avoid NSAIDs in patients receiving anticoagulants, systemic corticosteroids, lithium, loop diuretics, and other interacting drugs. In summary, anti-inflammatory medications are potent drugs with important adverse effects. These drugs inhibit prostaglandin protection. Potential adverse drug events include renal, kidney, and hypertension. Corticosteroids are superior but come with risks. NSAIDs reduce chronic and acute inflammation. Both therapeutic and adverse effects can happen secondary to COX enzymes.